So we have a syndesmosis. And so, and as we look at that, we want to remember a couple of things. One, that the inferior joint, even though it's part of the ankle, has a pivoting action for the superior joint. So it's much more stable. We want it to be stable. We need it to be stable, but there's a little motion occurs there. And the superior joint goes into, the general joint plane is anterior, lateral, posterior, medial, although there's some variety in the shape of this, so you want to find that curvature if we have it, especially if we're going to manipulate. So we have that big rotary moment, but any syndesmosis or bicondylar joint also has a superior-inferior component to that. And that probably is one of the dominant functions of that joint, as well as to give it axial rotation. Because the superior-inferior moment is part of the loading mechanism when we have it attached to the biceps, the sacrotuberous ligament, all the way through the posterior sling, and then all the way through the underneath the foot through the peroneals. And so that's what we want to remember. So the first thing we'll look at is the axial motion of it, and we want to be on the tibial tubercle, and just not at the, I think the easiest place to feel the joint motion is not at the tip of it, but just a little bit below the tip of it, because that's where the articular plane tends to lie. So if we go into right axial rotation, so the whole body rotates to the right, the tibia and the fibula go into right rotation together, and then the fibula's moment is taken up, and the tibia continues to rotate. So the relative end position of the fibula is in its posterior medial moment. So it should go posterior medial at the very end of that rotation. And come on back. And so we should feel a glide. And then as we go into ipsilateral rotation, we go into left rotation. Again, the fibular moment is taken up, tibia continues in its rotation, and so we get an anterior lateral glide. He feels a little bit stiff in that position. Let me just look here quick. Okay, right. And left. So immediately, clunk. Come on back. That actually clicked in his fibula. That's just interesting when he's forcing his rotation. So immediately it looks like he's limited anterior in this position in weight bearing. And the next thing we want to do is when we go into dorsiflexion, at the inferior joint, when we go into weight bearing squat, which is dorsiflexion, as the talus shifts back into the crus, we get an abduction moment of the fibula as it spreads, and it actually comes into internal rotation. So it comes forward and it shifts the fibula up. So we have a vertical moment. So that's part of that vertical weight-bearing moment that we need tension in. And come on back up. So what we can do with the squat is now, as he comes down beyond the superior aspect, as he comes down, we should feel the fibula go up, and this fibula goes up more than this one immediately. So that's what we're looking for. And I don't know how your balance is. In plantar flexion, the opposite occurs. So as he goes into plantar flexion, as he comes up, we should see the fibula descend. So with plantar flexion, the fibula descends. So the conjunct position of the fibula is when it goes into the anterior lateral glide, it should go in, it should go down. It should go up. As it goes in anterior lateral glide, it should go up. As it goes in posterior medial glide, it should go down. So those are functions. So anterior lateral glide, go up. Its functional moment is dorsiflexion, plantar flexion. It's going posterior, medial, and down. And so in weight bearing, we know with all weight bearing joints, when we're looking at some things that are unstable, look more stable in weight bearing. So if we're looking for hypo or a loose joint, we've got to check it in non-weight bearing. So I'm going to have you lay on your back. So just again, try to find a comfortable place. So the common peroneal nerve is coming within the first quarter inch in general, and the anatomy says the common peroneal will be there. So you just need to find a comfortable place that's not on the nerve. And then we're just going to go into posterior medial glide and anterior lateral, so he still feels fixated anterior lateral like he did in weight bearing. And this one clunked, so we want to know what's happening here. Posterior medial, anterior lateral. We can't really tell anything there. And then we're going to actually go ahead and straighten your legs, because we're going to look at the superior glide and the inferior glide. So since we already said it was restricted in anterior lateral glide, we would expect the superior glide to be restricted, and it is. Come here, got a nice big glide there. Okay, so that was our assessment. And going into treatment, if we have an acute joint, we might try muscle energy first. So I'm going to have you sit up, swing that way. So since the bicep femoris is attached to the fibula, we can use that as a moment. Okay, so if he was stuck posterior medial and we wanted to go posterior medial, we can control the tibia through our knees, and we want to go posterior medial, so we're going to be on the front of the fibula, and we're going to ask him to flex. Use his bicep and relax, and flex again, and relax, and then just take up the position. If we want to go into the anterior lateral joint, there's a little bit of controversy of whether the anterior tibialis anterior attaches to the fibula. There's a lot of reference that it has fascial ties into the capsule, but the other one that actually attaches strongly is the extensor digitorum, so we can use extensor digitorum. So lift up your toes, good, and relax, and we're going to go anterior lateral, and lift up your toes, and relax. So muscle energy. The traditional way of manipulating, so we have to see it hypomobile, weight bearing, and non-weight bearing. If we're going to go into posterior medial, lay on your back. What we want to do is internally rotate the tibia so we bring the plane a little more close to vertical. I'm going to push this up so it's out of the joint position. And again, finding something where we don't have pressure on the nerve, and straight arm technique, little overpressure first to make sure you don't have any reactivity, and then the manipulation would be straight arm posterior medial. And the traditional posterior lateral is on all fours. And I'm going to have you come down. Is this the leg? This is the leg, right? Okay, we'll go this way. So then you just have them get their butt out of your way by coming up. Okay. And so now, again, anterior lateral. We can correct the tibia just so we bring the plane a little more in the vertical position, and somewhere is that okay?
Yep.
Doing a straight arm technique. Okay, lay on your back. Okay, so that was good enough to fix his. So that's the traditional way. And the other thing that I was working on and talking to you about in class was this. The ones that are more difficult are difficult because they don't have the superior and inferior moment. So they're sublux. So they're sublux forward or backward, and they're not taking the weight-bearing load. And so then we get adaptations in the ankle, foot, knee, and hip related to that. So lay on your right side.
Hello? Here, Gail.
So, if it's posterior medial, so it's fixated posterior medial, so we're having the trouble with the weight-bearing dorsiflexion. We can't go superior. Then we're going to come, I'm going to be right back behind you. Okay. Right back here, I'm going to get on the malleolus, try to find a webbed grip that's comfortable, get on the back of the fibula. And again, it's anterior lateral, so find the plane of the joint, and a two-handed technique. Good. I actually loosen them up a little bit more. And if we wanted to go, I'll go the other way now. Oh, the other thing that you can do if you're having difficulty with your, either the kneeling one or this one, we can do a percussion manip. And you need to really be careful of where you're at with that nerve, because it really will give us strong tenelles, but we can do that to it. And that works reasonably good. And then, to go the other way, we're going to do posterior medial. Now I'm going to get a key grip, grab down the fibula. Oh, I won't do it, sorry. I was getting all excited. So, the moment is two-handed. So we're pulling as we're pushing backwards. Now, a couple more things. So that's all the manipulation for the superior joint. If the superior joint is not maintaining itself, it's hardly ever completely unstable. And so it's not maintaining itself. You make sure you look through the kinetic chain, but within the superior tib-fib complex, we talked about the interosseous membrane down here having these oblique deep fibers. And Jan, why don't you come up here, because I know yours is tight in here. And so her joint is actually moving pretty well, but if we look right here at her fibula, remember that in dorsiflexion, it's going to go into internal rotation. So about midway up is where the interosseous membrane is attaching, and that is kind of probably myofascially held, but we want that little bitty rotation. So that just feels, I don't know what it feels like, tight?
It's tight and a little tender.
Okay. So we need that little bit of motion there. So from the back, and I also think we can get right here on the front of that fibula and just kind of go through the soft tissue, and usually there it is right there. That little point where the myofascia is just gripping hard the interosseous tissue, so it's not allowing that rotation moment. So getting right in there. So these kind of things, same in the radio-ulnar joint, will hold that superior inferior moment from occurring. Good. Lay on your belly, Jen. Let me just look at this. And then the last thing is, there's been a lot of controversy whether we should manipulate the inferior fib joint at all, because we really want a stable mortise. Okay, Jen, you're a little bit stuck. You okay?
Yeah.
Okay. So in class I talked about, it always seems that the fibula has to go forward no matter what's happening up there, and I think it's because the articulation of the fibula on the tibia is very anterior in the joint. The joint looks large, but the actual articulating moment is about a third of the joint, and the rest is a compressive interface with fibrocartilage, so it helps give it stability. And so I think what happens here is it's that little bitty twisting moment. So it's not so much an anterior posterior glide as it's probably that little bit of internal external moment. And so if you can't get it, the rest of it, then we'll come in, stabilize the talus. Okay, Jen?
Mm-hmm.
And that should give it up. And that's all I know.
Question, how far up would you go with the interosseous?
Well, so all of these, so just stay on your belly for 1 second. So the soleus, the posterior tib, the flexor hallucis, all attach on the septum up here. But the septum up here, in the anatomy, has not as deep of fibers. But I think that if you're having some chronicity where you're having the tugging, you can go up high. If we look from the front, lay on your back, then the tib anterior, so tib anterior here, and then we have extensor digitorum right next to it, and then extensor hallucis longus right here, coming here, and they all attach also in the membrane. And so I think you can work those soft tissues, but it's very curious that it's the same as this, where it tends to be right here, and I think it's the rotation moment, and lay on your left side. And so I think it is this obliquity in these lower fibers that are gaining stability for the mortise down low, because that's very different than everything else in this. So, I mean, I think you should loosen up any way you want, but this seems right here to be the problem on all of the ones that I've seen. I was going to say one more thing.